Hello,
Hello, Dr. Ashram. How are you?
I'm good. Thanks for asking. How are you doing all?
Good, thank you.
How are your studies going?
Good. It's pretty busy, hectic.
Yeah. So, most of the students ask for the questions, explanations from the exams, right? So, I
Yes,
will
sir.
ask the coordinator to share the explanations after the exam because we are unable to, like, we have lots of things and a tough schedule. So, sometimes we are unable to reply or explain the question, right?
Yeah,
So,
yeah.
we will send you the explanations after each and every exam. Give them a reminder if they did not share it on time. All right.
Yes, sir. Yeah.
So you can confirm your results. Okay. All
Okay,
right.
sir.
I
Thank you,
think
sir.
it's 10, 11 minutes. So yeah, we will start, right?
Okay, sir.
And one more question. I think we have covered almost all the anatomy, physio, and pathology, right?
Yes, sir.
Today's questions, most of the questions are from the previous topics, right? Some of us, like 15 to 20, are new. The remaining are
Okay.
from the previous questions, like similar concepts.
So which day are we doing today?
It's day 7. Yesterday,
Day 7. Okay.
yeah, and Doctor did, I think he done the day 8 questions, right?
Correct.
So
Yeah.
we have one more day of the pathology. If you wanna do it, we will definitely do it. And if you wanna do it on your own, because it's 25 questions, and I guess most of the topics are done, right?
I
If
think
you go
maybe we
through
can
your,
just only go over the
Mhm.
questions that we haven't covered, like those topics only maybe, and the ones that we've already done, maybe we can do those on our own.
All right. So I think tomorrow
Like
we
just
have.
few of those, the few of the main topics that we haven't
Mhm.
done, maybe we can do those and then we can jump on the other day
Like,
questions so that
what
way we
what do you
can
think?
save
Which
more time.
Yeah, what do you think? Which topics haven't been done till now?
I'm just going
Any
to look at the document.
any guess? I guess from the first
I
grade.
think we covered pretty much
From the
everything.
first grade, I think, yeah. So the things that are remaining are pharma only, I think.
Like the
Yeah.
pharmacology,
Pharma.
most
Yeah,
of
so
Yeah.
the
the
pharma.
pharma, so yeah, we will have like 2 days for pharma. We have almost
Yeah.
80 or 90 questions from the pharma, right?
Yeah.
So
There were
let me
some
know.
questions
Mhm.
from physio that were remaining. I don't know if you want to do those, sir.
Yeah, I think I'm very much ahead of the physio.
I can imagine. Me too.
Yeah, because
Yeah.
there's
Did
not
we
that
do
much of
the vasculitis questions?
no, yeah. So vasculitis, tomorrow we will do the vasculitis questions, okay? All right.
Okay.
Okay.
Can you see my screen?
Yes, sir.
All right. I guess we have some new students. It will be a little bit difficult for them to understand because today's questions are mostly from the previous concepts. I will try to give little bit of explanations, but yeah, we'll see, okay? Anyone?
Which of the following is most closely associated with this patient's heart valve findings?
Mm-hmm.
A 56-year-old woman with unknown medical history is brought to the emergency department in an unresponsive state. Paramedics were called for sudden onset, left-sided weakness, and when they arrived at the patient's house, she was having a generalized tonic-clonic seizure. Anti-seizure medications were given, and the patient was subsequently intubated. Evaluation shows a comatose woman with left hemiplegia. Neuroimaging
Mhm.
reveals a large infraction in the right middle cerebral artery territory
Mhm.
with cerebral edema. Despite aggressive interventions, the patient dies from brain herniation. Autopsy reveals multiple small, non destructive masses attached to the edges of the mitral valve leaflets. Microscopy shows that these masses are composed of platelet rich thrombi, but no organisms are present. Which of the following is most closely associated with this patient's heart valve findings?
Yeah, so I think from these, just from these three uh, points, you can understand the pathology, right? So all the stem from here to here is of what happened to the patient?
Stroke.
Stroke.
Stroke, right?
Yes, sir.
Yes.
So, so they haven't given something related to the cardiology, and we didn't have like any high yield thing over there. Just we have stroke, right? So we are not concerned about the type of stroke, the cause of stroke. They are asking about the cardiological findings, right?
Yes.
Yes, sir.
All right. All right. Autopsy reveals multiple small, non-destructive masses on the edges of mitral valve leaflet. So, and microscopy reveals platelet-rich thrombi, but no organism. So we have endocarditis, right?
Yes.
So we have an endocarditis.
Infective endocrine.
It's not infective.
Yeah, so we don't
There's no
have
organism.
No organism. Yes.
organism, right? So we have sterile and along with the platelet-rich thrombi. So we call this as non-bacterial or merantic, right?
Yes,
Yes.
sir.
Merantic endocarditis, right? So now, which of the following is most closely associated with the patient's heart valve finding? So what is the association? So simply, if you know, what are the main causes of non-bacterial endocarditis? What do you think? Sorry. So we have malignancy, advanced malignancy, specifically or most commonly which type? Pancreatic adeno, pancreatic adenocarcinoma, right? So remember these 2 points, they are very high yield. They come in most of the questions, so that you should know these things, whether the uh, thrombi is sterile or we have pathology organisms, right? So either it's infective or non-infective, right? Now we have to remember the causes. They are important. Advanced malignancy, and the second is
Autoimmune disorders.
SLE, right? Yeah, autoimmune, most importantly, SLE. We call it Libman sac, right? So we have questions on SLE and we have question on advanced malignancy. So do we have any sign and symptoms of SLE?
No.
No.
No, right? And what about advanced malignancy?
I think they've told us about the masses. So
Yeah. So where does we have a mass? Sorry.
edges of the mitral valve leaflets.
Okay.
But
So most
that's what they're talking about but that's when they're talking about these platelet-rich thrombi, not exactly the mass,
Yeah.
There is no
right?
yeah,
sign
and
symptom for
Because they're
yeah,
malignancy.
they're telling us about the microscopy. But I think out of all the
yeah.
options that
Out
they've
of all
given
the
us, the
question,
one
so
that
yeah,
makes the most sense is malignancy. Other
advanced
answers
malignancy,
don't.
right? So
Yeah.
they haven't given you neither the sign and symptoms of SLE or advanced malignancy. So it can be either of them, right?
Yes, it's
Right?
more like we have to occlude out what makes
Yeah.
sense. The other question,
So
other answers
it
don't.
is, yeah. So it is one of the cause, right? So if they have given you SLE and advanced malignancy both together, so they would have given you the sign and symptom of either of them, right? Right, guys?
Yes. Yes.
And what's common between both of these conditions that lead to the platelet rich, the endocarditis? So
They cause hypercoagulable state.
hypercoagulable state, right? So because of the hypercoagulable state, they have also given you like chronic liver disease, so it can be causing you the hypercoagulability, right? And dilated cardiomyopathy. So it can cause a thrombus and can lead to stroke, but not the involvement of mitral valve leaflet and masses attached on the edges, right? Right, guys?
Right, yes.
Yes, sir.
And this is one of the cause of infective endocarditis, right? IV drug abusers, mostly involving the tricuspid valve. And some same over here, the vasculitis, it can also cause hypercoagulable state, but it does not cause endocarditis, right?
Yes.
So pretty
Yeah.
simple question. And I think yesterday we had a question, maybe I'm wrong, but I think yesterday we had a question on the endocarditis, right? So the concepts are easy. Remember two things, advanced malignancy and SLE, and we will have platelet-rich thrombi, okay? All right, because of
Yes,
the
sir.
hypercoagulable state, okay?
Yes, sir.
All right.
I can read this. This
Yeah.
patient's hoarseness is most likely caused by a 34-year-old Asian female is hospitalized with progressive exertional dyspnea,
Mm-hmm.
lower extremity edema, and cough. She also describes frequent nocturnal episodes of breathlessness and recent hoarseness. She does not use tobacco, alcohol, or drugs.
Mm-hmm.
Auscultation reveals loud first and second heart sounds and a mid-diastolic rumble, but best heard at the cardiac apex. This patient's hoarseness is most likely caused by.
Yeah, so
So
they are asking about the cause of the hoarseness, right?
that is of
Right?
enlargement of the mitral,
On the left atrium.
sorry, left atrium of the left
Transstenosis.
atrium. That's why it's causing
Mhm.
Ortner
Stenosis.
syndrome.
Yeah, so it's most likely Ortner, right? So let's
Yes.
Correct.
discuss it, okay? So we have a 34-year-old female with a progressive dyspnea, lower extremity edema, and cough. Dyspnea, edema, and cough, right? So pulmonary effects of heart, right? Right, guys?
Yes,
So
sir.
Yes.
we can get some pathology in the right heart, right? So let's guess we have like pathology of this side, okay? She also described a frequent nocturnal episodes of breathlessness, and so the breathlessness again, symptoms from the cardiac effects, and we have now a hoarseness. So she does not use tobacco, alcohol, or drugs. Auscultation reveals loud first and second heart sounds and a mid-diastolic rumble, best heard at the cardiac apex. So apex, right?
Mitral area, yeah.
Mitral, yeah.
Mitral area, right?
Mm-hmm.
Mitral
Mitral.
And
stenosis.
diastolic, diastolic,
Yeah, stenosis.
Yes,
diastolic
Vital
stenosis.
is
Mitral
edema,
stenosis.
Vital stenosis, yeah.
right?
Yeah.
Now you will understand the uh, what we can say the sign and symptoms. If we have mitral stenosis, so the pressures are increased here,
Yeah.
causing
In the
the
left atrium.
pulmonary
Left atrial hypertrophy.
pulmonary congestion, right?
Yeah.
Yes.
And now we have to come over to the causes of the uh, hoarseness. So the left atrial enlargement can
Mm-hmm.
compress
Recurrent laryngeal.
Yeah.
Recurrent laryngeal
esophagus
nerve.
and recurrent laryngeal nerve.
Laryngeal nerve.
So in
Nerve, yeah.
such case of compression of recurrent laryngeal nerve, we call it Ortner syndrome, right?
Yeah.
Yes. And
Yes,
we
sir.
get
And
hoarseness.
we all know the left atria is
The most
Left
posterior.
behind. The most posterior. Okay.
Yes.
All right. So, what do you think about your options?
Nerve
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 impingement.
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 Nerve impingement, right? So,
Yeah.
Yes.
laryngeal edema can be the cause of hoarseness, impaired arterial supply, epithelial sloughing, and vocal cord polyps. So, they can be the causes of hoarseness, but not related to mitral stenosis, right?
Yeah.
All right. So, I think pretty clear question on the nerve impingement, right?
Yes.
I haven't given you a picture. That's not a problem. All right.
Okay. Which of the
Can I
following is the
go?
most likely? Okay. Go.
Yeah, no, no, go, go.
Which of the following is the most likely cause of this patient's murmur? 19-year-old man comes to the office to establish medical care. He is transitioning care from his pediatrician. The patient states that he recently changed his glasses for myopia. He otherwise has no symptoms. He takes no medications. Vital signs are within normal limits. On physical examination, the patient is tall with the long upper extremities and fingers. The face appears narrow with a down slanted palpebral fissure, flattened malar bones, and a small jaw. The lungs are clear on auscultations. A late systolic murmur is present at the cardiac apex.
Mhm.
The abdomen is soft and non-tender with no organomegaly. Which of the following is the most
Mhm.
likely cause of this patient murmur?
So, what do you think we have? We have a thin, tall patient with long upper extremities and small
Myopia.
Marfan.
bones.
Marfan.
So, we
Marfan.
have
Syndrome.
Yeah.
Marfan, right?
Yeah.
And what about the murmur?
It's mitral valve prolapse mostly.
Yeah.
Yeah.
Like,
So, simply,
yeah.
if even you don't know the prolapse, so from the location of the sound, apex and
Yeah.
systolic, so it's
Sorry.
mitral regurg caused by
Regard.
mitral valve prolapse. Okay.
Yeah.
All right. So now what are they asking? Which of the following is most likely the cause of this patient murmur? So what do you think?
Myxomatosis mitral
Yeah.
degeneration.
Relation.
Yeah,
Yeah,
D.
Ixomatous metal.
so we have myxomatous mitral regeneration. So it's
Degeneration.
already discussed, right? It's already previously discussed, but uh, can we discuss it again a little bit or no?
Maybe you
So,
can just give a little summary, not like a huge
Okay.
explanation.
All right. All right. All right. So what happened in the Marfan is Marfans, we have fibrillin mutation, right?
yeah.
And what does fibrillin do? So remember two important functions, okay? Stabilizes the um what do we say? Okay, myofibrils components, okay? So stabilizes the myofibril
Elastic
components.
fibers.
Yeah. So simply or more simple, elastic fibers. And what's the second function? Regulates the TGF beta, right? It's a type of uh, mm, or a regulatory protein from a matrix which is responsible for cleavage of elastic fibers. Okay, so I am making it very simple. Okay, so two things are regulated by fibrillin. So the elastic fibers are regulated or maintained, the elasticity is maintained. The thing that is being regulated is TGF beta. Okay, and what does TGF beta do? In case of mutations, in case of fibrillin mutation, TGF
Remodeling.
beta is increased. Okay, all right, and in
Okay.
increase of TGF beta, or we can say the mutation of fibrillin, the cleavage of elastic fibers occurs. Okay, all right, and the collagen density is increased. Okay, sorry, decreased. Okay,
Okay.
all right. So when we
Yeah.
have cleavage of the elastic fibers, or we can say the collagen of the density, the collagen density is decreased. So we have like pooling of, so we have pooling of, simply remember the extracellular matrix proteins, that is TGF beta, okay? So it's normally regulated in case of fibrillin mutation. It is overexpressed and leading to the breakdown of the collagen. So we have like a matrix where extracellular matrix we have where we have the breakdown products, all right, and pooling of the glycoaminoglycans, okay? And this is a form of myxomatous degeneration, okay? All right.
Yeah.
All right. So the things you have to remember is fibrillin functions, and the mutation leads to the overexpression of TGF beta, okay, which is leading to the breakdown of the elastic fibers and accumulation of the aminoglycans, okay, in the same extracellular matrix, okay. So it's a kind of gelatinous matrix, gelatinous secretions, so we call it maxomatous, okay. All right.
Okay.
Okay,
Yes.
sir.
Yes, sir.
And the same was true for the maxomatous, was true for atrial maxomas, right? So
Yeah.
the mechanisms are different. Just the name is similar because it's more of a mucinous or mixed type or mucoid type of secretions. Okay, so the both the things are different. Just the matrix is mixed type, or we can say mucoid or gelatinous. Okay, that's why it's called myxomatous mitral degeneration. All right,
Yeah.
and the secretions by atrial maxoma, they are also mucinous, okay. The mechanisms are different, the pathophysiology is different, just the nature of the secretions are mucinous, okay.
Okay.
All right. Yeah, so all the other things like aortic root dilatation, so we have excluded like the aorta, right, just from the murmurs. All right. And same
Yes.
for the papillary muscle rupture, so it does not cause the, what we can say over here, why, anyone, why not the papillary muscle rupture?
It's not MI and it causes mitral recurrence, not MVP.
Yeah, so it's a complication of MI, right?
Yes.
And fibrous deposition. Fibrous
Mm.
deposition, they occur
Uh,
in the carcinoid, okay?
oh,
Carcinoid syndrome, okay?
okay.
Okay.
Met, Mets from, or we can say Mets from liver, that is also mostly from the GI, right? Carcinoid, right?
Yes, sir. Mm.
And what else? Yeah. So the question was simple. We have made it complex for ourselves just to get some extra knowledge. All right. So the thing is, you have identified the murmur. All right. And they have given you simple pathognomonic signs of the marathon, right? And everyone knows marathon causes mitral valve prolapse and mitral regurg, right? Right, guys?
Yes.
Yes, sir.
Yeah.
Yes, doctor. Yeah. Right.
Okay. Mhm.
Which of the following underlying condition most likely predispose this patient to developing these cardiac changes? A 36-year-old woman is brought to emergency department with sudden onset right-sided weakness and speech difficulty. During last 3 weeks, the patient has experienced progressive fatigue, malaise, and low-grade fever. Despite the
Mhm.
symptoms, she did not seek medical attention and did not take any medications. She had a
Mhm.
dental extraction 5 weeks ago, which was uncomplicated. The patient has never previously been significantly ill or hospitalized. She worked as a receptionist at the legal firm and has never traveled outside the United States. She does not use tobacco, alcohol, or illicit drugs. The patient is admitted to hospital, but despite adequate resuscitating measures, she dies 2 hours later. Gross autopsy
Mhm.
show a large, friable, irregular mass attached to the atrial surface of the valve. Which of the
Mhm.
following underlying condition most likely predispose this patient to developing these cardiac changes?
So, can you summarize it?
It's like 36 year old woman. She has a complaint
Mhm.
of right-sided weakness and speech difficulty.
So we have a stroke patient, right? Most
Yes,
probably MCA, okay? So
yes.
we are not going in the detail of the stroke. So it can be when we think about the heart disease, so most probably it's an emboli from the heart, right?
Yes.
So we have
Yes, sir.
stroke and it could be emboli. So let's see what the question is talking about, okay?
Okay.
Yeah, so we have a stroke and go on, please.
Yeah,
So
she
we
had
have a text.
like yeah 3 weeks before she had a history of fatigue, malaise, and low-grade fever, like infection
Yeah,
history.
so so we have 3 weeks before she had infection.
Infection. And
Okay.
she had a dental extraction 5 weeks ago, but that was
All
uncomplicated.
right.
It
So
could be some
5 weeks, so we
respective.
will write it in chronological order, right? So 5 weeks dental procedure. So I think it's clear now, right? So five
But
weeks ago
it's
we have dental procedure, then after 2 weeks of the dental procedure, or 3 weeks before the uh, complaint, the current complaint. So she had infection, right?
Yeah.
Yes.
And
Then
let's
she
see. Mm-hmm.
then she died suddenly, and on the
Okay.
autopsy there is friable irregular masses attached to the
Mhm.
atrial surface of the valve.
All right. So, what do you
Yes,
think
sir.
about the surface they have mentioned? Why they have mentioned the surface?
These
Because
vegetations,
vegetations will be there on the surface.
Endocarditis?
Yeah,
the veg
infective endocarditis.
So,
Because of the dental procedure, maybe?
Yeah.
no, but I am more concerned about they have mentioned the atrial surface. The
because
vegetation
this is
is
on
if
the
this
one
is.
mitral
surface.
valve
If it's
collapse, MVP.
Mm-hmm.
because if
Yeah.
vegetation is on the both surface, then the diagnosis is different. It's just on one side. I think so.
Yeah. So,
I,
anyone else?
is it because of ASD?
No,
This
I
is
think
I
it's
don't
mitral
think.
infective
valve
endocarditis.
collapse.
The
Yeah.
infective
So I
endocarditis.
will explain
These
it, and we
vegetations.
have. Yeah. So we have a question on the
Tumor or no? Malignancy or no?
both sided the vegetations. Okay. So just
Yeah,
remember.
because if it's
Yeah.
that's lip map sex syndrome that have the vegetation on both side of the valve, but
Yeah.
here is
Great.
the one
Great. Great.
side, so this is infective endocarditis most
Yeah.
probably, if I'm
Great.
not wrong.
Yeah, so if the vegetation is on the only on the atrial surface, so most probably it's due to infections, okay?
Yes,
All right.
Okay.
And in case of non-bacterial or merantic, so it's like SLE, right? So it's
yes,
an autoimmune, so it can be on both sides. All right. But infective, they are only on the atrial surface, okay? Atrial side of the valve, okay?
yes.
Okay.
All right.
Yes.
Yeah,
Yes.
so
But
and one more important concept. So let's again summarize the question. So we have a patient of stroke. She had 5 weeks ago a dental procedure, and after the 2 weeks of the dental procedure, she had an infection, right? And now
yeah.
she died suddenly. And on autopsy, we have valve problem, right?
Yeah.
So most
Yes,
probably she died of endocarditis,
Endocarditis.
right? Leading to maybe stenosis. First, it's regurgitation and other problems. Okay. So, yeah. And what are they asking? Which of the following conditions predisposes? Yeah. So, this is also an important point, uh, or the differentiating point between the uh, acute
Yeah.
and subacute endocarditis, right?
Yeah.
Yes.
So the difference between acute and subacute. So we have which type of endocarditis we have? Is it acute or subacute?
Subacute, sir.
Subacute.
Subacute, right?
Yeah.
And most probably bacteria we call it strepviridin, right?
Yeah.
Yeah, dental
So we have,
procedure.
yeah. So dental procedures, strepviridin, and subacute, right?
Yeah.
So the predisposition point I am concerned about is in case of acute or staph aureus, right? It affect
Yes.
Normal valves.
normal or healthy valve, right?
Yes.
Yes.
Or and in case of subacute,
Also, IV drug users. Mm.
yeah. So we are not
Okay.
going in detail of that, okay?
Okay.
I am making the differentiating point between the acute and subacute, all right? So
Okay.
in subacute, it affects the already
Damaged
Yes.
wall.
damaged or affected valves, right?
Okay.
Yes.
All right. So predisposition means we have subacute. So it is the patient may have also have some previous cardiac problem, right?
Yes.
All right. So what do you think?
E.
What do you
E.
think?
E.
A.
E mostly.
E or
E.
A? E, right?
Regurgitant. Yes.
Regurgitation.
Okay. So anyone who can give me other predisposing cardiac anomalies that can lead to uh, subacute endocarditis.
Rheumatic heart disease, right?
So I will give you four high yield points. Okay. So if we
Okay.
have bicuspid aortic valve, all right, VSD, PDA, and tetralogy of Fallot. Okay. So in most of the conditions, along with the mitral valve prolapse, okay, so we have mitral valve prolapse and these conditions. Most of the time, when we have such conditions, or we can say congenital anomalies, the patient after infection develops the subacute endocarditis. All right.
Right.
All
Okay.
right.
Yeah.
So the ASD is not there because of
Mm.
the pressures. They are causing the turbulence flow. All right. Coronary
Okay.
artery disease. So they are not the predisposing factor for uh, endocarditis. Okay.
Yes.
All right.
Yeah.
Hypertrophic cardiomyopathy along it's not, it can cause thrombus. No, sorry, dilated cardiomyopathy causes thrombus, right?
Mm. Yes.
Yeah, and mitral annulus calcification, so it's age related, right?
Yes.
And another thing we have mentioned bicuspid aortic valve. So yeah, bicuspid will calcify in early age, okay?
Yes. Okay.
Right? So there are some high yield
Mm.
points. The question again was very easy. We have simply diagnosed our condition is mitral valve prolapse. Sorry, the condition is identified as subacute endocarditis, and we all know endocarditis most commonly involve mitral valve.
Mitral
In case
Mm.
of drug abusers, it involves
tricuspid.
Yes.
tricuspid,
Mm.
right?
Yes.
And they have simply given you the classic cause, which is dental procedure. Okay,
Yes.
Yes.
so
Yes, sir.
Option E, right?
Yeah.
Yeah. So you guys were tired of the uh, questions from the murmurs, and today I guess we have lots of murmurs. So it will be a good revision, okay?
Good.
Oh, yes.
Yeah.
Thank you. That's very.
May I?
Mm-hmm.
Which of the following is the most likely cause of this patient's physical findings? A
Mm-hmm.
74-year-old man comes to the office for a follow-up visit for
Mm-hmm.
hypertension. His last visit was a year ago. He has no chest pain, shortness of breath, leg swelling, or dizziness. The patient is compliant with his medications and can tolerate moderate level physical activity.
Mm-hmm.
Blood pressure is 145/75. The pulse is 67 and regular. Auscultation findings at the base of the heart are depicted in the exhibit below. Which of the following is most likely cause of this patient's physical findings?
Yeah, so can you summarize the question?
Yeah, 74 years old, follow up for
With
hypertension.
hypertension, right? Yeah.
Yes. And he doesn't have
So,
no complaints, no chest
mm-hmm.
pain, no
Mm-hmm.
leg or swelling or dizziness. He's compliant with medications and moderate physical activities. Blood pressure is like mildly elevated systolic, and
Mm-hmm.
pulse is regular.
Mm-hmm.
Heart rate is good, and the auscultation shows that at the base of the heart, this murmur, like systolic murmur.
Yeah. So we
Um,
have, this is important, right? The base of the heart, right?
yeah,
Yeah. And we have S1 to S2 is systole, right?
systolic.
And this is diastole,
This one.
right? And what do you think is in mid systolic, right?
Yeah, crescendo, decrescendo.
Yes.
And crescendo,
Aortic
decrescendo.
stenosis.
So
Yes,
what do you think we have?
aortic stenosis,
Yeah, aortic stenosis.
So at the base,
Pulmonary.
right?
the base of the heart.
Base of the heart, or if simply we can say, right? Upper
Upper
sternal border.
sternal. Yeah.
And we have systolic murmur. So again is a revision. Aortic, stenosis, and mitral regurg are systolic, right?
Yes.
So we have aortic stenosis, right?
You know. hmm
Yes.
Let's see what are our options. All right. And look over to the age. So age is also important, right?
74. Yeah.
Yeah, because
Will be complications.
calcifications are
Yes.
mostly occurring in the 70s and 80s, right?
Correct.
Mm. Yeah. Which of the following is most likely of this patient physical findings? So we have systolic, crescendo, decrescendo murmur at the right upper sternal border, right? And
Yes.
we have diagnosed this is in aortic stenosis, right?
Stenosis.
No.
Yes.
So even if you don't know something like if we don't know the ankylosing spondylitis, I guess you guys have done the MSK, right? So you should be knowing this. But if even you don't know the condition, so you should have the knowledge of the high yield points, right?
Yes, sir.
Yeah. So at least you should have the knowledge which is given in the first aid, right? So start from the caudal rupture. So what does it cause when we have caudal tendon rupture?
Valve prolapse.
Record. Okay.
Mm-hmm. Yeah. So mitral regurg and
Yeah.
Mitral
Prolapse.
valve
prolapse, right?
prolapse.
What about coronary artery disease? Is it causing any murmur?
No.
So not affecting the murmurs,
Pulse.
not yeah, not directly. It can lead to like we have discussed something in uh, PDA occlusion causing the postromedial valve effect and all these, right? but
Yeah.
it also will lead to maybe recurrence, right?
Mhm. Correct.
Due to the wall rupture, but not necessarily, but not stenosis. Okay.
Yes.
All right.
Yeah.
Yes.
What about the cystic medial necrosis?
That's
Aneurysm.
aortic dissection.
Yeah, so they
No,
are
that
talking about the medial wall of the aorta, right?
Yeah.
Yeah.
So if we have necrosis of that wall, so we have aortic root dilatation, aneurysm, and dissection. Okay.
Yeah.
Yeah.
Infective endocarditis.
Mm. Yeah.
What about infective endocarditis? It's causing mitral and aortic regurg, right?
Recurrent. Yeah.
Yes.
Yes.
Right. And
Yeah.
the sounds of them are also different. And we have
Yeah.
our diagnosis of aortic stenosis. Okay.
Mhm.
Yeah.
Rheumatic fever.
Mm.
There
Yeah.
is no
What do you think?
symptoms of
Usually a
rheumatic
mitral
fever.
valve involved,
Mhm.
younger age.
Yeah.
Yeah. So remember the high pressure valve are mostly affected in the rheumatic fever. Okay. And then uh, it can affect the low pressure valve. All right.
Mhm.
Yes.
Yeah.
And the thing is, in acute case, it causes regurg, okay?
Okay.
Yes.
Yeah.
All right, and then it leads to stenosis, okay?
Calcification, stenosis. Yeah.
And also, we didn't have any sign and symptoms, only we have hypertension, right?
Correct.
Yes.
Yeah, right ventricular failure. Do we have any sign and symptoms of right
No.
ventricular
No.
failure?
No.
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 Valvular calcification. So
Yes.
Yes.
age,
Related.
Age.
hypertension,
Mm-hmm.
Mm.
and
Yes.
the aortic stenosis. So all this can be due to
Calcification.
valvular
Valvular
calcification.
calcification.
All right.
Yes.
Yeah.
Yes, sir.
All right. So what do you see in the picture?
Splinter hemorrhage.
Splinter hemorrhage.
Splinter
Easy,
hemorrhage.
right?
Mm.
Infective endocarditis.
Yeah.
So further evaluation would most likely reveal additional abnormalities. So they are talking about additional abnormalities. Yeah. So the picture says splinter or flame-shaped hemorrhages. So what's the cause of these hemorrhages?
Obstruction of the, I think it's obstruction.
And who is causing the obstruction of the vessels,
This small,
small vessels?
small emboli, right? Some.
Microemboli, right?
Yes.
Yeah, so remember the cause is microemboli, right? So anyone question? Do you want to read the question?
Okay, so I can read it.
Mm-hmm, mm-hmm,
Um, a 24-year-old woman comes to the physician with a 3-week history of progressive fatigue. Physical
mm-hmm,
examination shows lesions involving the nail beds, as seen in the
mm-hmm.
photograph.
Yeah, in the
Further
photograph.
evaluation,
Mhm.
further evaluation would most likely reveal additional abnormalities during which part of the physical examination.
So we
Cardiac.
have progressive fatigue from 3 weeks, right? And we have splinter hemorrhages, and now they are asking about the so progressive fatigue
Fatigue.
in 24-year old, right?
Yeah.
So the questions are easy, and I am intentionally making it difficult, all right?
It's good we can discuss a lot of things
Further
before this.
evaluation would most likely reveal additional abnormalities in which of the following examination. So, what do you think?
Cardiac auscultation.
Cardiac
Cardiac
auscultation.
Cardiac muscle.
Yeah, yeah. So, can you guys just quickly go through the bacterial endocarditis, uh, other findings? Like we have this one, right? So, what else we have?
Rot
New
spots.
onset murmur when you do
Mm-hmm.
cardiac. Yeah. Regurgitation.
Yeah, so they have given you a great mnemonic. Everyone should memorize that because most of the question will be coming from that exact mnemonic, okay?
John Way.
From Jan, right?
Mm-hmm.
From Jan is
From
a
Jan.
mnemonic, okay? From Jan. So it's given in your book, all right? So the F is fever, right? Rot
Mhm.
spot in retina, okay? And O is oscillor
Notes.
nodules. M is murmur. J, Janwell lesion. A is anemia. What else? What did I write over here? From Jan, sorry. So it's N, right? N is not
Well, I'm
working.
thinking the Jan is a Jan Way. The JN is just Jan Way.
Jan, okay.
Yeah.
Yeah, so Janwell lesions, anemia, and N is for nail bed
Nail.
hemorrhage, okay? These. And the last one is emboli, okay? So what are the rot spots? Retina, right? So
Yes.
they
Yes.
are white dots in the retina, okay? And oscillor nodules. So remember the oscillor nodules, they are
And
not from the emboli, okay? They are not from the emboli, all right? The Janway lesions, they are from the emboli, okay? The nail beds, what do we call it? Flame shape or splinter hemorrhages, right? So they are from the emboli blocking the vessels, right? But the oscillor nodules, they are painful and they are due to immune complex deposition, okay? All right, immune complexes deposition, okay?
Okay.
Yes, sir.
All right, so they are painful, all right? And the other one, GNV lesions, they are painless, all right?
Okay.
Arithmetic, and yeah, if they have given the picture, so it would be good, okay? So you will understand if any other picture. So if they have given you one of the picture from this, so it can give you the other picture as well, right?
Mhm.
They are important. Remember them. Yeah. So splinter hemorrhages. Yeah. So we don't have the pictures. So go through the first aid. The pictures are important. Okay.
Okay.
All right. Anyone?
Which of the following substances would have helped in the diagnosing this patient? A 35-year-old man is evaluated for progressive fatigue and shortness of breath. Recently, he has noticed bilateral leg swelling and abdominal distension despite overall weight loss. He does not use tobacco, alcohol, or illicit drugs. Despite treatment, the patient dies several weeks later. Autopsy revealed a significant endocardial thickening with the dense fibrous deposits around the tricuspid and pulmonary valve as well as moderate pulmonary valve stenosis. Left-sided cardiac chambers and valves are normal, measuring the level of which of the following substance would have helped in diagnosing this patient.
So we have an interesting case. 35-year-old, the shortness of breath, bilateral leg swellings, right?
Yes, and
And
abdominal
abdominal
distension.
distension,
Distension.
right? So yeah, he does not use tobacco, alcohol, or illicit drugs. Despite treatment, the patient dies several weeks later. Autopsy reveals significant endocardial thickening dense fibrous deposits on tricuspid and pulmonary valve, as well as pulmonary stenosis. The left cardiac chambers are and valves are normal, right? Measuring the level of which of the following. So, what do you think your diagnosis is? We have
Does he have
right-sided heart
ascites?
involved.
Carcinoids,
Right.
Yeah,
Arsinoid.
so only the right-sided heart is involved, right? We
yes,
also have
Yeah.
an abdominal distension, right? And
Yes.
leg swellings, right? And the biopsy is very specific for carcinoid. Okay, so you haven't discussed such biopsies till now, right? Dense
yes,
fibrous deposits, right? Endocardial thickening and dense fibrous deposits, right?
yes,
Yes.
Along the mitral, tricuspid and pulmonary valve. And this one, the left-sided chambers are normal. So we have normal
carcinoid,
left heart, right? In the carcinoid, right?
yes.
So So anyone knows about or some details about the carcinoid syndrome?
That 5 hydroxyindole acetic acid is
Yeah, so it will
elevated.
be high, right?
Yes.
So carcinoid tumor is a
So,
neuroendocrine tumor of the proximal colon or
Yeah.
small intestine, right?
Yes.
And because
If they
of that,
metastasize
we have
the liver, they will cause
we
some
have
symptoms.
the so because of the involvement of the intestine in the colon, so we have distension,
There.
right? And they have when they have mets to liver, right?
Yes.
So now the hormones that is being secreted are directly poured into blood. All right.
Yes,
Yeah.
And from the blood, when it goes to lungs and comes over to the left side of the heart, so the lungs have monoamine oxidase, right? MAO, right? Right, guys?
Yeah.
So it is breaking down the secretions of mets, okay? That's why this side of the heart is not affected, and the blood that is coming directly in a venous circulation is affecting the right side of the heart. Okay,
Yes.
so the reason for the normal left heart is monoamine oxidase in the lungs. Okay,
Okay.
all right,
Yes.
Yes, sir.
and because of the right heart failure, we have bilateral leg swellings and ascites as well, right? So distension can be due to right heart failure. Okay.
Okay.
All right. And for the diagnosis, we have
C indole
hydroxy
acetic acid,
indolic,
indole, indole
yeah,
acetic acid.
indole acetic acid. Okay. And so we have serotonin, right? So one of the important secretions is serotonin. Okay. And the end product of the serotonin is 5 hydroxy indole acetic acid. Okay.
Okay.
Yeah, it's one of the metabolite.
Yeah. Anyone?
Which of the following processes underlies the patient's current condition? A 68-year-old man comes to the office due to exertional shortness of breath and fatigue, which have progressed over the past year.
Mm-hmm.
The patient has a history of hypertension, but medical history is otherwise unremarkable. He is a lifetime non smoker. His father died of a heart attack at age 70. Blood pressure is 144 by 74, pulse is 72 and regular. Cardiac auscultation reveals a 3 by 6 ejection type, late peaking systolic murmur, and a barely audible S2. The murmur diminishes in intensity during the straining phase of the Valsalva maneuver. Which of the following processes underlying this patient's current condition.
So we have, as in summary, we have 68-year-old man with the exertional shortness of breath and fatigue, right? He has a history of hypertension. Other uh, father died, so it's not significant. So only history of hypertension. Now we have an ejection type, late peak systolic murmur, and barely audible S2, which is
Yeah.
decreased by Valsalva. So what do you think we have?
Aortic stenosis, late peaking systolic murmur.
Mm-hmm. Yeah.
Ejection,
So they
ejection
haven't
murmur.
Yeah, so they haven't given you the location, right? So most of the students confused about the location, right?
Yeah.
So if
They,
the yeah, so if the location of the sound is not given, but if you look over here, we have given the a clue of barely audible S2, right?
Yeah.
yes.
Right? And S2 is
Yes.
because of aortic and pulmonic valve,
Pulmonary.
right?
Yes.
Yes.
Yeah.
Aortic and pulmonic valve closure, right?
Yeah.
Yeah, so now they are asking about the cause of the sound, right? So let's assume either it's a aortic stenosis, right?
Yes.
So most probably it's aortic stenosis. The sound can be similar to hypertrophic cardiomyopathy as well, right? Late peaking systolic murmur, right? The late
Yeah.
peak or the mid peak shows the severity, right?
Yeah.
So the
Mm,
aortic stenosis and hypertrophic cardiomyopathy, both the sounds are similar, right? So the aortic stenosis is heard in the right upper border, right?
Yeah.
Yes.
Right upper
Upper
sternal border,
external.
and
second
Yeah.
HCM
intercostal.
is second. Yeah, so right
Yeah.
second, and the HCM is heard at the left sternal border, right?
Yes.
Yeah.
But they did not have given us the location, right? So based on
Yeah.
the location, so it can be aortic stenosis or HCM, right?
HCM.
Hypertrophic
Yeah.
Yes.
cardiomyopathy.
Yeah, but if you know the late peaking systolic murmur, so it's a specific for aortic stenosis, okay? But let's see other important points as well, so that we can confirm it's in aortic stenosis, okay?
Okay.
Yeah. So what about the S2? So S2 is either aortic closure or pulmonic closure, right?
Yeah.
Yeah.
So we can exclude from the S2 point HCM, right?
Yeah.
Yeah.
So the question is now becoming easy just from the murmur. If you don't have the location, so we can say it's aortic stenosis or HCM. Now, from the clue of the S2, we can say it's in aortic stenosis, right?
Yeah.
Yeah.
Yes.
Yeah, what else? Now, what are they asking about? Valsalva. Yeah,
Mm,
we have yesterday discussed the HCM and the aortic stenosis are different when we are doing the maneuvers, right?
Mhm. Yeah.
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 Mhm.
Yeah, so
Yes.
so again,
Yeah.
based
Right.
on the maneuvers,
Yes.
if
Right.
we have HCM and we perform Valsalva, or just remember the cavity size,
So,
okay?
right. Yeah.
So what does Valsalva do?
Increase as
Decreases
decreases HCM and MVP murmur.
No,
yeah.
you are right, but I'm just
decreases
asking
preload.
about, yeah, so
Yeah. After load
decreases
also.
the preload. So if this is heard, right, and after decreasing preload, so the left ventricular cavity size now it's like this, and now it's
Smaller.
decreased, right?
Yeah.
Yeah.
Decreased with a decrease in preload, right? And
Yeah.
in HCM, the aortic valve is being compressed in between the mitral and septal enlargement, right? So whenever
Yes.
the size of the cavity is decreasing, the murmurs will increase, okay?
Yeah.
Yes.
Right? And here,
Yes.
the valsalva is decreasing, diminishing the murmur, right? And aortic
Yes.
stenosis, it's opposite, okay? Decreasing the preload will decrease the sound, okay?
Yes.
All right?
Yes.
Yeah.
So, yeah, so they have given you the sound and they have given you two clues, okay? All right?
Yeah. But I
Now,
think those questions are easy now.
mhm.
But in the exam, if you have like less than a minute, I think we need to
Yeah,
like,
yeah. So,
yeah, it will be difficult actually.
yeah, so but the thing is, if
Yeah.
you do the question yourself again and again, and
Yes. Yes. Right.
you have the memory of not going all the details, you have just by saying late peaking murmurs and barely audible as two, so it's aortic stenosis, straightforward.
Yes.
Okay, yeah.
Yes,
So
sir.
cardiac hypertrophy is being removed, right? Maximatus
Yes,
valve
B.
thickening. Mm-hmm. So it's
B.
B.
B,
Calcifications.
right?
Yes.
Calcifications, right?
Yes.
68 years of age. Okay. Any question?
No. Well
All right.
explained. Yeah.
Mm-hmm.
Which of the following is most likely predisposing factor for this patient presenting condition? 53-year-old man comes to the emergency department due to fever and progressive weakness over the
Mm-hmm.
last 2 weeks. Yesterday, he also developed shortness of breath. The patient immigrated from Eastern Europe 2 years ago and says he was diagnosed with a heart disease in this distant past, but he doesn't recall any details. He doesn't use tobacco, alcohol, or illicit drug. Despite receiving appropriate medical care, the patient expires during hospitalization. On autopsy, gross examination of the heart shows large friable masses on the mitral valve and extensive destruction of the cuspid tissue. Which of the following is the most likely predisposing factor of this patient presenting condition?
So, what do you think our diagnosis is just from these autopsy findings and previous history of heart disease?
Mostly the patient might have this rheumatic heart disease.
Mm-hmm.
Uh, yeah, causing yeah
Yeah. So, which of the following is
vegetable
most likely? Yeah. So, rheumatic heart disease is affecting the
mitral valve.
Travel.
valves,
Endocarditis.
right?
Endocardi.
Mm.
Endocarditis, right?
Yeah.
Yeah.
And they are asking which of the following is most likely predisposing factor for the this patient presenting condition. So
E.
predisposing factor is valvular inflammation in scarring,
Uh,
right?
yeah.
So I guess we should end the class. Everyone knows the things are, I guess, easy, right?
Because you did great explaining at the beginning, doctor. Now everything is easy.
We are all doing
So,
together, therefore it's easy. If it is come to do sitting alone,
Yeah.
then
Yes.
then it's
Yeah,
nightmare
Combine
for
effort,
me.
we get it right.
Yeah. Right.
yeah. So yeah, so I guess who should read will explain the question as well. Okay. So let's see if it's easy now or not. Okay. All right. Yeah. Anyone new? Anyone new?
Uh, which of the following processes was the most likely initiating step in the pathogenesis of this patient's condition? A 53-year-old man comes to the emergency department due to fever and progressive weakness over the last 2 weeks. Yesterday, he also developed shortness of breath. The patient immigrated from Eastern Europe 2 years ago and says he was diagnosed with heart disease in the distant past, but he does not recall any details. He does not use
Mm-hmm.
tobacco, alcohol, or illicit drugs. Despite receiving appropriate medical care, the patient expires during hospitalization. On autopsy, gross exam of his heart shows large, friable masses on the mitral valve with extensive destruction of cuspal tissue. The blood cultures obtained from these patients on admission grow Streptococcus species. Which of the following processes was the most likely initiating step in the pathogenesis of this patient's condition?
Yeah, so the same person who have read the question, what do you think your diagnosis is? Bacterial, had previous
Bacteria.
history as well,
Non
now have
non-bacterial.
infection, and mitral valve is affected. So what do you think your diagnosis is?
Infective endocarditis.
Yeah, so we have our diagnosis of infective endocarditis. Easy, right?
Yes, sir.
So a bacteria which is causing the mitral valve cuspal destruction, right?
Yeah.
So the mitral valve cusp are being destroyed due to infection, right? And he had also a previous history. So not necessarily the previous history is important in cases of staph aureus, but if it's not the staph aureus and others, so it is important, right? Yeah. So which of the following process was most likely initiating step in the pathogenesis of this patient condition?
Mhm.
What do you think?
Fibrin, fibrin deposition. Bacteria form the platelets, fibrin platelets on the valve.
Yeah, so you're right. Anyone else? Anyone else?
Sorry,
What
but
about this
why
white
not?
cell
Why? Yeah.
infiltration? Why not
Yes.
E?
So
Like an infection first, like this, the bacterial infection.
Yeah.
yeah, that's a great question. Yeah. So anyone who knows fibrin, so why fibrin? Yeah, so let me discuss
Yeah,
it. Yesterday we have discussed the uh, atheroma formation, right?
Yeah.
And
In
atherosclerosis. We have discussed the atherosclerosis, right?
Yes.
yes.
Yeah.
Yes, endothelial
And
damage.
the
the
first
easiest
one,
point,
endothelium, endothelium
Endothelial damage and then clotting,
invasion. Yeah.
yeah. So the
activation.
Um,
first, yeah, so the
mhm.
first or the initials of the condition is we have previous heart disease, right? So the initials of the conditions and before the infection, okay? Before the infection, before the infection or the bacteria comes over, the steps are the steps or the pathogenesis is same, okay? Same endocardial injury, all right?
Yes.
Sorry. Yeah, so same. Give me a second, sorry. Yeah, so we have same injury, endocardial surfaces is injured, right? And we have platelets and fibrin attachment, okay? All right. And then
Yeah.
after the platelets and fibrin accumulation, we have, if in case we have bacteremia, all right, we have some infection. So it further activates the coagulation and the vegetations of the valves occur, okay? So initials are the same, platelets and fibrin accumulation, okay? All right.
Yeah.
And one other point to be remember, or for making it simple, the thing is that what do you think the vegetation if we look into the vegetation, what type of cell will we have? So if we look it, so we will have platelets, right? We will have fibrins, right? RBCs, WBCs, and microorganisms. Okay, all right. So the vegetation consists of platelets, fibrins, RBCs, WBCs, and microorganisms. Okay, all right.
Yes, sir.
Oh, yeah. Anyone?
Sir, I can read.
Yeah.
Uh, 1 second, sir. Which of the following is the most likely cause of the cardiac findings seen in this individual? A 64-year-old man suddenly dies while playing tennis. In the preceding months, he experienced fatigue and some exertional dyspnea. Autopsy is performed. The heart examination shows left ventricular septal thickness of 1.6 centimeter. Normal is less than 1.1. Posterior wall thickness of 1.6 centimeter and an internal left ventricular diameter of 3.2 centimeter. Normal is 3.5 to 5.9. No focal myocardial scarring is seen. Which of the following is the most likely cause of the cardiac finding seen in this individual?
So we have 64-year-old man dies while playing tennis. Okay. In preceding month, he experienced fatigue and some exertional dyspnea. So he had a history of fatigue and dyspnea. Autopsy is performed, shows the left ventricular septal thickness. So septal thickness is 1.6, right? Posterior
Mm,
wall thickness is also 1.6. Okay. And in
yes,
internal left ventricular diameter. So thickness is
is
almost the
increased.
same, right? So thickness of the septum and
Yeah,
thickness of the wall both are 1.6, right?
yes,
And now the ventricular diameter. So left ventricular diameter, or we can say left ventricular size, 3.4, 3.2. So less, right?
yeah,
Normal is 3.5 to 5.9. Right, guys?
yes,
Yeah.
It's
sir.
concentric. That's
So
concentric.
Hypertrophy,
yeah, so as a summary, it's a
concentric hypertrophy.
concentric
Mm.
hypertrophy. All right. No focal scarring is seen. So we don't have any scars or
Yeah.
MI such things. Which of the following is most likely the cardiac findings in this individual? So what do you think could be the cause of the concentric hypertrophy in a 64-year-old man?
Aortic
Yeah.
stenosis.
Aortic
Aortic
stenosis.
stenosis,
Yeah.
hypertension, pressure.
Yeah,
Hypertension.
so
Yeah,
Chronic
aortic
hypertension.
stenosis, severe hypertension,
Mm.
and what else? What else could be the cause of the hypertrophy?
Pressure overload.
Yeah, so all these three can lead to pressure overload, right? Hypertrophic
yes,
cardiomyopathy, hypertension, and aortic stenosis. Okay, all right.
yes, sir.
Yeah.
Yeah,
Okay.
dilated cardiomyopathy. What do you
No.
think? Eccentric,
Eccentric.
eccentric,
Yeah.
right?
Eccentric.
Mitral leakage, so volume overload, right?
Volume
Yeah.
overload.
Volume overload.
So all the things have been discussed, right? So we don't need to go in detail of that. Okay, coronary
Yes.
artery obstruction, but we don't have any scars, right?
Yeah.
Rheumatic mitral stenosis. So yeah, if you remember, we have discussed one of the question on the mitral stenosis, which is I have told you the only condition which does not affect the left
Left
ventricular
ventricle.
pressure, right?
That's
It
right.
only
Yeah.
affect the left atria, right?
Left ventricle. Yeah.
So mitral stenosis does not have anything to do with the left ventricular pressures. Okay,
Yes.
Yes,
all right. Aortic stenosis. Yeah, anyone? So again, the volumes things are given. Okay.
Which of the following is most likely cause of cardiac findings seen in this individual? A
Yeah,
64-year-old man dies suddenly while playing a tennis. Is this the same question? Eleven.
I guess so. Let's see.
Uh,
It
in the
looks same.
The
preceding,
options are different,
in the
I guess.
preceding month, the patient experienced fatigue and some exertional dyspnea. Autopsy revealed rupture of an unsuspected ascending aortic aneurysm. Heart
Mm-hmm.
examination shows septal thickness of 1.1 centimeter, normal is less than 1.1, and a posterior wall thickness of 1.1 centimeter, normal is less than 1.1. An internal left ventricular diameter of 6.8 centimeter, normal is 3.5 to 5.9, so it's enlarged. No focal myocardial scarring is seen. Which of the following is most likely cause of cardiac findings seen in this individual?
So we have increased thickness, right?
No, no.
Yes.
No.
Normal,
Decreased
right?
thickness.
So we have normal,
Septum.
No,
right?
normal
Or
Normal
less than or
thickness.
thickness.
equal to. So normal
Yeah,
thickness,
1.1.
This
yeah,
is
right?
eccentric.
And
Yeah.
increase ventricular cavity size, right?
yeah,
Yeah.
Yes.
Eccentric.
So it is eccentric, right?
yes.
Yes.
Aortic
Dilated.
regurg.
Mm.
So what do you
Vol-
think?
Aortic
volume of
regurgitation.
Aortic
Volume
stenosis,
overload.
yeah.
Mm.
So recurrence,
Aortic
right?
treatment. Yeah, yeah.
Yeah.
This patient was most likely suffering from which of the following conditions? A
Mm-hmm.
38-year-old woman suddenly collapses at home after experiencing severe chest pain and dies before reaching the hospital. Postmortem examination reveals an occluding thrombus overlying a ruptured atherosclerotic plaque on the left anterior descending artery. The patient is also found to have thickened mitral wall leaflets with multiple small vegetations on both valvular surfaces and fibrinoid necrosis of arterioles. Other findings include glomerular capillary basement membrane thickening with wire loop changes. This patient was most likely suffering from which of the following conditions?
So now you have endocarditis, right?
Non-infective.
Yes.
Non-infective, right? So
Yeah.
we have both the
Women.
surfaces, right? I have told you
Yes.
in
Yeah.
previous
Yeah,
question.
Oh,
Both the
yeah.
SLE.
surfaces are involved, right?
yeah, yes.
And the patient died because of MI in the LAD, right? So in a
Yeah,
Yes.
summary, we have a patient of endocarditis, which is she's died because of the LAD obstruction, all right. And she also had fibrinoid necrosis of the arterioles, and she also have glomerular capillary basement membrane thickening and wire looping. So we have discussed this in the renal,
mm,
right?
SLE.
It should be
SLE.
SLE.
SLE. Oh, okay.
Glomerulonephritis.
So we
yeah,
have glomerulonephritis, right?
Mhm.
yeah.
Yeah. So which type of merantic or
Diffuse.
non-infective?
Hmm?
We have two causes, SLE or
SLE.
malignance,
Mm,
right?
yeah,
And SLE can cause renal.
Diffuse
yeah.
proliferative.
It can involve
The kidney, whatever. Basement
kidney,
membrane.
right?
Basement membrane, yeah.
Yeah,
Mhm.
so basement membrane thickening, the wire looping. So it's a diffuse proliferative glomerulonephritis. Okay.
Okay.
So SLE option.
D. Yeah.
Okay. All right.
Which of the following is the most likely cause of this patient's heart condition? A 75-year-old man comes to the office due to worsening dyspnea and fatigue on exertion over the last 6 months. Recently, he has had severe lightheadedness during physical activity. Blood pressure is 125 over 65, pulse is 65 and regular. Physical examination reveals a harsh ejection type systolic murmur at the base of the heart, radiating to the neck. The second heart sound is diminished in intensity. A fourth heart sound is heard at the cardiac apex. Which of the following is the most likely cause of this patient's heart condition?
So again, they have
S2
given
is
you the second
soft,
heart sound is the second
diminished.
heart sound is diminished, ejection type of systolic murmur at the base. All
Yeah,
right.
it's
So
aortic
we have
Yeah.
stenosis.
discussed this in
Aortic
great details,
stenosis.
right? So we
Yeah.
Yes.
have aortic stenosis of the 75-year-old man.
Yeah.
All right. And now
Yes.
he is having fatigue and dyspnea over the last 6 months. So let's see why the fatigue and dyspnea. And the second heart sound is diminished. Fourth heart sound is heard at the cardiac apex, right? So we also have stiff,
Ventricles.
Ventricles.
stiff ventricles. Okay.
Yeah.
Which of the following is most likely the cause of this patient?
A.
Valve
Hey.
calcification with impaired
A,
leafing.
right?
Yes.
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 So not maximitis, not infective vegetation, not hypertrophy, and not fusion of the commissures. Okay.
Yeah.
So the calcification based on the age and aortic stenosis we have discussed, right? And the
Yeah.
sign and symptoms, yeah. So the fatigue and dyspnea, it could be due to decrease outflow, right?
Yes.
And the blood pressure of 125 at such age,
Low.
and also feel of the fatigue and dyspnea. So it is decreased outflow, okay? And
Yeah.
we have H for heart sound. So left ventricle is stenosed because of left ventricle is stiff because of the high pressures due to aortic stenosis. Okay,
Yeah.
Yes.
so extensive valve calcifications. Yeah, aortic stenosis. All right.
This patient is at greatest risk for developing which of the following conditions?
Mm-hmm.
A 10-year-old boy is brought to the physician by his parents due to restlessness and involuntary jerking. He takes no medications and his vaccinations are up to date. His
Mm-hmm.
parents do not recall any recent injuries or illness other than a sore throat 3 months ago. On examination, the patient has rapid, irregular, jerky movements involving his face, arms, and legs. This
Mm-hmm.
patient is at greatest risk for developing which of the following conditions?
So in a summary, we have 10-year-old with a history of sore throat, right?
Yeah.
And involuntary jerky movements, right?
Yes.
Yeah.
So what do you think he is at the greatest risk of?
Valvular heart disease.
Valvular
Valvular
heart
heart
disease.
Valvular
disease.
heart disease.
So
Yeah.
most
Rheumatic
probably
heart.
Rheumatic
sore
heart
throat,
Rheumatic
Rheumatic
fever.
fever.
rheumatic fever, and it
fever.
can lead to rheumatic heart disease,
Heart
right?
disease. Yeah.
Yeah.
All right. Valvular heart disease. Sorry for the new students. I think they would be not liking the today's class, right?
Doctor, those jerky movements, they were Sinham Korea, right?
Yeah.
Yeah.
Yes.
Okay. Mhm.
So anyone?
So I can read.
Yeah.
This finding is most likely the result of which of the following conditions? A 42-year-old woman is brought to the hospital due to right sided weakness and difficulty speaking. She has a long history of a diastolic murmur, but her medical follow up has been poor. She does not use tobacco, alcohol, or illicit drugs. A CT scan of the brain reveals a large ischemic stroke involving the left middle cerebral artery distribution. The patient dies 2 days later due to progressive neurological deterioration. An autopsy exploration of the left atrium shows diffuse fibrous thickening and distortion of the mitral valve leaflets, commissure fusion at the leaflet edges, and narrowing of the mitral valve orifice. This finding is most likely the result of which of the following conditions?
So, on autopsy findings, we have diffuse fibrous thickening. Sorry, give me a second. All right. So, diffuse fibrous thickening and distortion of the mitral valve leaflets, commissural fusion of the leaflet edges, and narrowing of the mitral valve orifice, right?
Mitral
Yeah.
stenosis.
So, we have stroke, right?
Stroke. Yeah.
Yeah.
We have mitral stenosis, and the patient is 42-year-old,
Mm.
right? She does
Yes.
not use tobacco, alcohol, or illicit drugs. Yeah, the finding is most likely because of which of the following condition? Yeah, so stroke,
Mm.
we can say from the emboli form, right? In
Emboli.
heart.
Yeah.
Yeah.
Yes.
So could be, it could be one of the
Rheumatic.
cause, right?
Active endocarditis.
And about the diffuse fibrosis, thickening, and distortion of the mitral valve leaflets. So, what do you think?
Rheumatic fever
Rheumatic fever.
causing rheumatic heart disease.
Easy, right?
Yeah.
So, rheumatic fever, I've told you first is mitral regurg and it becomes mitral stenosis, right?
Yes.
And
Yes.
infective endocarditis, most of the time it's regurg, right?
Yes.
So, yeah, if you look over to the other options, infective endocarditis, rheumatoid arthritis, rupture of the papillary muscles. Yeah, so I don't think they are related, right?
Yes.
Like rupture of the papillary muscles, we have discussed this, and rheumatoid arthritis, so not that much high yield. All right. So it can be a like the some of the things could be common, but emboli from the left atrium and mitral stenosis causing the middle cerebral artery infarction. So most likely rheumatic fever. Okay. And the autopsy is high yield, okay? The diffuse fibrous thickening and distortion of the mitral valve leaflet, and then it becomes narrowing of the mitral valve orifice, right?
Yes.
Yes, sir.
All right.
Which of the following is the most likely diagnosis? A 35-year-old premi-gravid woman comes to the clinic during a second trimester. The patient reports that she has had some tiredness, which she attributes to pregnancy. She takes one nap during the day. She has no chest pain, cough, or lower extremity swelling. As a child, the patient was told that she has a murmur but doesn't know any details and says that she has felt well until recently. On physical examinations, a 3 out of 6 mid-systolic murmur is heard at the left upper sternal border, and S2 is widely split. Which of the following is the most likely diagnosis?
Yeah, so we have a 35-year-old woman comes to the clinic in second trimester. The patient report of some tiredness and she relates it to pregnancy, right?
Yes.
No chest pain, no swellings, no edema. Child, as a child, the patient was told that she has a murmur. but she does not know any details and says that she has felt well until recently, right? On
Mhm.
physical examination, we have mid systolic, left upper sternal border, and S2 is widely split. So, left upper sternal border, what do you think?
It should be like a
Uh,
Harmonic.
S2
Harmonic
split,
the area
pulmonary stenosis.
So, pulmonic
stenosis.
area, right? And
Pulmonary
Yeah,
area.
ASD as
and
well, right?
Is
But
yes,
the
the wide
Yes,
split is 2 is pulmonic
pulmonic
stenosis.
stenosis.
stenosis, okay?
Hmm.
So, we have diagnosed is a pulmonic, so straightforward question, right? They just
Yes.
want to
Stenosis.
know if you have the understanding of the location and the sound concept, right?
Hmm.
Yeah.
All right.
The patient's condition is most likely related to an abnormality involving which of the following tissues? An 18-year-old woman is referred to a cardiologist after a heart murmur is discovered during a routine checkup. The patient is healthy and has no symptoms. Medical history is unremarkable. She runs daily and wants to start actively training for a half marathon. The patient is concerned that the murmur is a sign of heart disease. She has no
Mm-hmm.
family history of sudden cardiac death. Auscultation reveals a mid systolic click followed by a short, late systolic murmur at the cardiac apex. The murmur disappears with squatting. The patient's condition is most likely related to an abnormality involving which of the following tissues?
So, apex
So, mitral
and
area.
systolic. So, we have mitral area, right?
Yes.
Systolic murmur, systolic murmur,
Mitral regurg.
mitral regurg, right? But the
Yeah.
mid systolic click is specific for mitral valve prolapse, okay?
Prolapse.
Prolapse.
So, remember the mid systolic click is for mitral valve prolapse,
Prolapse.
okay?
Prolapse.
The patient condition is most likely an abnormality in which of the following. Uh-huh.
Connective tissue.
Connective tissue.
Right? Who is talking? Let me mute her. All right. So we have problem in the connective tissue, right?
Yes.
So I think the questions are getting easy. Yeah, so we have mitral valve prolapse, right? And we have explained the maneuver previously. All right. Yeah. So what do you see over here in the picture? And
Emboli.
erythematous swelling on the palm, right? Hello?
Yeah.
Yeah, so what do you see here? An erythematous swelling, right?
Yeah.
Yes.
So let's see which of the following do which of the following do this patient's skin lesion most likely represent? So they, yeah, anyone?
I can go. Skin examination shows non-tender lesion on the palms. A representative lesion is shown in the image below. 32-year-old man brought to emergency department with a several-day history of high-grade fever, dyspnea, and fatigue. The patient's temperature is 39.4, blood pressure is 122/70, and pulse is 102 and regular. Physical examination reveals a new hollow systolic murmur with a
Mm-hmm.
blowing quality that is best heard over the cardiac apex. Skin examination shows non-tender lesions on the palms. A representative lesion is shown in the image below.
That's a lesion where. Genway
Read for me for
lesion,
quarter, please.
painless.
Oh my
Give me a second, guys.
Alright. Effective
Yeah.
endocarditis.
Yeah.
Is she muted? Yeah, so what do you think?
Genway
Is
lesion,
January lesion.
lesion
January lesions, right?
microembolism.
Yeah.
And what's the
Microembolitis
murmur?
skin vessels.
What's the murmur?
Mitral
One
Sinus
more more.
systemic normal.
mitral
Regurg. Mitral regurg.
regurgitation.
Mitral regurgitation.
Yeah, meteoric geyser. Heard of the apex.
So I guess the murmurs are pretty easy now, right?
Yeah.
Um, yeah. So we have mitral regurg and Janway lesions. So what's the question asking?
D.
D. Oh,
Micro,
Microembolitis skin vessels. Yeah.
microemboli, right?
apply. Yeah.
Yeah.
And immune complexes. The oscillor nodes are due
That
to
would
immune
be
Yeah.
complexes, okay?
Osler
You
node.
know.
Yeah.
Yeah.
Osler node.
Osler nodes, they are painful, okay? Just from the pain,
Careful.
if you know the oscillor nodules are painful, so you will understand it's a like a autoimmune pathology, okay?
Yes.
So option D, right?
Yeah.
Yeah.
All right. So I will skip the graph questions. Today is not a good day to explain the graphs, okay?
So,
All
sir,
right.
sir, I have
Yeah.
This
a
one.
question.
Yeah.
I have a question. So microemboli causes two things: splinter hemorrhage and that lesion that we
Genuine.
saw, genuine lesion.
Genuine.
Germination.
Okay.
Yeah. Yeah. So the blood clots or the blockage of the vessels, okay? That's causing the splinter hemorrhages and Janway lesions, okay? And both of
Okay.
them are painless, okay? The Janway
Yeah.
lesions are on the palms and soles, and yeah. In nails, we have splinter hemorrhages, okay? All right.
Yes, sir.
Yeah.
But the oscillate nodes are painful, right, sir?
Yeah. Remember it from the book I've given you a pretty good mnemonic is ouch.
Ouch.
Osler. Osler
Yeah.
to ouch.
Ouch.
From
Ouch.
chair.
Oh, ouch. Painful, okay?
Okay.
A sound when, yeah. All right.
Yeah.
This is
Okay.
okay.
Thank you.
Yeah.
All right. So, yeah, anyone?
I
Which of
can.
the following
Uh-huh.
Which of the following is most likely cause of the patient's symptoms? This
Mhm.
item's associated media require use of headphones. Please ensure your volume is audible. 23-year-old woman comes to the office due to exertional dyspnea. Occasionally has dry cough and had no chest pain, palpitation, or syncope. Patient immigrated from the Cambodia 3 years ago. Bilateral knee swelling as a child. Cardiac auscultations finding over the cardiac apex are given below. Which of the following
Mhm.
is most likely cause of the patient's symptom?
So, I guess, uh, so what do you think we have in sign and symptoms? We will hear the sound in a media, okay?
Yeah, with the migration, it's gonna be
So 23-year-old with the exertional dyspnea
Dry
and
cough,
dry cough, right?
mitral
Palpitations and
regurg.
syncope. And he is an immigrant and with the knee swelling and cardiac
rheumatic, or
auscultations.
Yeah.
And let's hear the sound, so it will make it pretty easy, right? But the
Yes.
sound is heard at the
Apex.
apex, right?
atrial area.
Apex, right? So mitral area, right?
Yeah.
So we will
Yeah.
focus on either the sound is of mitral stenosis or mitral regurg, okay?
Okay.
Yeah.
Yes.
most likely regurg?
All right.
Yeah.
Do you have
It's always
microphones?
systolic. Yeah, we
Yeah.
hear
It's
you.
all.
Solid.
It's always systolic.
Systolic.
Yeah.
Yeah.
So an immigrant, so most probably rheumatoid heart disease, right?
Yeah.
Yeah,
Yes.
D.
And with the
Like,
sign and symptoms of
Mitral
like
regurg.
yeah, dry cough and bilateral knee swellings, right?
Yeah.
So we have
Mitral
option
regurg. D.
D,
D.
right?
Yeah.
So, sir, why not mitral stenosis?
Just from the sound.
Yeah, that
It
from the
depends
yeah,
sound,
if there
yeah,
since
is
she
a
said it.
sound exactly.
sound.
And that
So,
would be
Because
Lera.
so how to
Yeah,
differentiate like how to tackle these sounds?
yeah.
Like
So
what?
yeah, if you have given like clear sign and symptoms, so usually they don't give you the clear because they want you to learn the sounds as well, right? So the holosystolic murmur, it's pretty easy when you hear it, okay? And the mitral stenosis, so the mitral stenosis is heard is in diastole, right?
Yes. Yeah.
And mitral regurg is in systole, okay? So it's pretty easy to when you hear it 2 or 3 times, so you will easily identify it, okay? So it's holosystolic, okay?
Okay. Okay.
So
Thank
from
you. So it
S1
means
to
that.
S2, from S1 to S2, it will be all the time, okay?
Okay.
And the diastolic mitral stenosis, I have told you, mitral stenosis is MS to OS, okay?
Okay.
Right? Opening snap. So you will hear opening snap just after
But the
S2,
sounds are
okay?
never
That's true.
clear. It's like it's going in seconds and it's never easy to identify the sound.
Yeah, the same problem. Yes.
You know,
Yes.
sir,
Yeah,
how
the
I just what I do usually. If like double up, like double up,
yeah, so
it will be. If it was like just you can do it like this. If after the second one it's diastolic. If like it come like this. If you
yeah.
hear the sound, you feel there is something in the middle, the whole thing. So that means it's like yeah, you need just to do it with your with yourself like this. I think
Yeah.
it will help. Yeah.
Thank you
I,
so
I
much.
guess I guess the she had explained very well, and the uworld explanatory videos are very good for that, okay? All right.
Okay.
Let me
Thank you,
show
sir.
you.
Thank you so much.
Let me show you that. Okay. So the first thing, we have made it easy just from the location. Okay. So the locations are very much important. Okay. And then classify it in systolic and diastolic sounds. Okay. So it has makes the question very easy to make it just to apex, so mitral, right?
Hmm.
And just we will have to focus on mitral stenosis and mitral rigors. Now if you are hearing the sound, so you will be focusing on two things only. Either you should be hearing opening snap, or the sound is hollow systolic, okay? So making the thing easy for yourself, and then after that, when you hear the media, so you will understand it pretty simply that either it's an opening snap or hollow systolic. Okay.
Okay,
Okay.
sir.
Thank you,
All
sir.
right. Now let me show you the hollow systolic, and these videos are very good. Okay. So go through these videos 2 3 times, and you will definitely get it. Okay. Now you have clear understanding of the hollow systolic, right?
Hmm.
And now let's see if they have given you mitral stenosis. So, no, though they didn't have given the mitral stenosis. So let's see if in any other explanation. Okay. All right.
Okay, sir. Thank you. Yeah, thank you.
No problem. Yeah. So we have another question on the media again. So let's see if we have an explanation. It. Okay. All right. Anyone?
Which of the following is most likely cause of this patient's symptoms? The item has associated media So, okay, a 54-year-old man comes to the office due to lightheadedness when walking his dog in the morning.
Mm-hmm.
He has had no chest pain, shortness of breath, weakness or headache. Cardiac
Mm-hmm.
auscultation findings and right sternal border are heard in the exhibit. Which of the following is most likely cause of this patient's symptom?
Right
Mm-hmm.
sternal border, aortic
Our
stenosis.
So pretty simple. It should be aortic stenosis, right?
Stenosis.
But if you look over here, we don't have given as
Leakage.
in aortic stenosis.
Bicuspid
But
aortic.
We
bicuspid aortic valve
Yeah.
can lead to aortic
yeah, great.
stenosis.
So bicuspid
Yeah,
aortic valve can lead to aortic
Here.
stenosis in early age, right?
Yes.
Yes.
Right. So let's see how does the aortic stenosis sound is okay. Can we play it again or
yeah, sir, you can play it again.
yeah, so you can appreciate the crescendo decrescendo, okay? All right.
Yeah,
So even if you don't know the sound, pretty simple from the question stem, okay?
yeah.
The location and the age and the understanding of the bicuspid valve, which can be in the early age can be calcified, okay? All right.
Yeah. So,
So, sir,
doctor,
when they're saying right sternal border, they're talking about the second intercostal space, right?
Yeah.
Okay,
So
because we were talking
second
about
and
On the
second
right side is
intercostal
your
space,
aortic area.
right
no.
side, it's in aortic area, right?
Yes.
area, yeah. Okay.
Yes. Doctor, so in AS, first or
Mhm.
second heart sound, they are not that much clear.
Sorry.
First and second heart sounds in AS, they are not that much clear, right? This is what I felt.
No, I think it's clear, but I guess you are more focusing on the first and second sound rather than the sound which was like first increased and then decreased.
Yeah, yeah, that's I get
Maybe,
it.
maybe the
Maybe yes.
sounds was not that much clear.
Yeah.
Yeah, but we don't have any specific. Maybe I don't know the specific physiology why the sound or not heard clear. Okay,
Okay.
so if anyone can clear your concept, anyone? Do we have anything like decreased S1 and S2 in aortic stenosis?
Because this is harsh murmur. When it is harsh, so
Yeah,
S2
so the
like
intensity
overlap
is more,
S1.
right?
So
Mm.
therefore,
All
although
right.
there is S1, but we cannot. That may be muffled because of this harsh sound of the
Heart
S2.
sound.
Hmm.
Yeah,
Okay.
so
And
Maybe
we
the
have,
cardiologist
yeah,
cardiologist can hear with the
yeah,
like the bell of the stat.
yeah,
yeah.
yeah.
So we have discussed in the previous questions the softer S2 and pulmonic stenosis and aortic stenosis, right?
Yeah.
So
Yes,
it
you're right.
becomes softer, but I don't know about the S1, okay?
Okay.
All right. So now again the third question from the same. Oh, we have discussed this one or it's a new question?
It's a no one.
All right.
Yeah, this left is Turner. That was
All
right.
right.
Correct. Alexstrom.
So 52-year-old man with increasing fatigue over the last 2 weeks. He also have been experiencing exertional dyspnea, occasional headaches. Cardiac auscultation findings on the left sternal border, which of the following is most likely. So what do you hear on the left sternal border?
Pulmonary
Aortic
SCN.
regurgitation.
oh, sternal, yeah. Sternal.
Pulmonary is left upper sternal, all right?
Yeah.
Sorry, yeah.
And aortic regurg, right?
Yes.
Yeah.
And what are the sounds? Aortic regurg is
Decreasing the
decrescendo,
Diastolic.
diastolic, right?
Diastolic.
Diastolic. Early
And this one
diastolic.
is, and this one is holosystolic, right?
Holostolic, yeah.
Monostolic.
So let's focus whether the sound is holosystolic or decrescendo, okay? So the focus will be on that 2 points only, or all right? All right?
Okay.
Yeah.
Mm-hmm.
Okay.
decreasing the.
It's diastolic.
Decrescent.
Yeah. Yes, it sounds like.
Decrescent.
Let's hear it again, okay?
Mm-hmm.
I heard it. Hold on. Holosystolic.
No.
It's
I
deep.
guess it's
It's
It's diastolic.
diastolic.
I guess it's
Is
diastolic, right?
Yeah.
Yeah.
Decrescendo type, right?
Yeah.
Yeah,
Yeah.
decrescent.
So aortic
It disappears
decrescendo.
in between.
Regurg.
And we also, I guess we also hear like uh first we hear S1, right? And then we have like two sounds and then the decrescendo, right? You can appreciate it, all right? Let's hear it again.
Okay.
Maybe I have heard it like that. I don't know. Let's see. What do you
Yeah,
think?
it's high blowing murmur, but it's decreasing the.
Yeah. So we have aortic regurg, right?
Yeah.
Yes, sir.
All right. I think the cardiology is all about the physiology and the sounds,
Yeah.
right? Yeah.
Yeah.
All right. Anyone?
Which of the following is the best indicator of the severity of this patient's valve disease? A 52-year-old man comes to the office with concerns about a heart problem. 3 years ago, the patient was told during a routine physical exam that he had a heart murmur. Currently, he has no specific complaints, but he mentions that he has become tired more easily in the past year. He has no chest pain or lower extremity swelling or significant medical history. The patient was healthy as a child and received all his childhood vaccinations. Blood pressure is 145/90 and pulse is 80 per minute and regular. Physical exam reveals a holosystolic murmur best heard at the apex of heart that radiates to the axilla. The lungs are clear on auscultation and abdominal exam is unremarkable. Which of the following is the best indicator of the severity of this patient's valve disease?
So our diagnosis is
Mitral
MR,
regurg.
MR.
Good.
mitral regurg, right?
Yes.
Yes.
And now they are asking about indicator that shows us the severity of the valve disease, right?
Yes.
So S3 is heard. in volume overload, right?
Yeah.
Yes.
S4 is
Stiff
stiff
ventricle.
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 Thickness of the ventricle.
Mid systolic click, I have told you, is
MVP.
MVP
MVP.
click.
S2 to opening snap,
MS.
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 right? Splitting of S2,
P
P.
P
PS.
PS.
PS, right?
Yeah.
Or can be ASD, but she was normal during the, and we have mitral regurg as well, right?
Mm.
So
Mm.
what do you think? So we have excluded MVP, mitral stenosis, pulmonic stenosis, right?
S3.
Now,
Three.
Presence of
Yeah.
yeah,
Volume
so
of
mitral regurg is leading to
volume over.
volume overload, right?
Volume overload.
And we will hear S3, right?
Yeah.
Right. And if we don't hear S3, it means we can exclude the mitral regurg, right?
Mm.
Yes.
Right. So they have given the radiation to axilla. So if it's not there and we have hollow systolic murmur and they given you is S3 is not audible, so it can be
Maybe less wear.
HCM.
right, the same murmur, right? Right, guys.
Yeah.
So if they have given you the same murmur, which is either due to mitral regurg or HCM, and we don't have S3, right? Or
Mm.
or they specifically mention that S3 is not audible, so it can be due to
HCM.
HCM, all right?
So, but isn't HCM the left sternal border of the location?
Yeah, sorry.
Yeah.
Sorry,
Yeah.
sorry. Sorry, you're definitely right. Sorry. All right. Anyone?
I can go.
Mm-hmm.
Which of the following best explains the murmur at the time of initial examination? 63-year-old man comes to the emergency due to progressive dyspnea fatigue over last week. He has not been able to lie flat due to difficulty breathing and had to sleep in a sitting position. He had anterior myocardial infarction 6 months ago and has not been compliant with the medication regime since then. Medical history is significant with hypertension. Patient is ex-smoker for 30 years, do not drink alcohol. Father died of a heart attack at age of 60. Blood pressure is 170, 100 plus is 100. O2 sats are 90% at the room temperature. Room air, sorry. Afebrile auscultation reveals crackles at the lung bases. And S3 gallop. 2 by 6 hollow systolic murmur over the apex. The patient is admitted to the hospital and after treatment with diuretics and vasodilators has improved significantly. Days later, there are no appreciable gallops or murmurs, but the best explains the murmur heard at the time of initial examination. So it's like a heart.
So a heart murmur, right? And she also have the symptoms of pulmonary congestions,
Yes.
right? So affecting the left heart, right?
Mm,
So maybe due to left heart failure, all right, and she had a history of hypertension,
yes.
right, and had been a smoker and also have an
Alcohol. Mm,
anterior MI. So she had a history of MI 6 months
mm,
ago.
yes.
Now she had a apnea, pulmonary congestions, right, and blood pressure is elevated, right,
Mm,
afebrile, so no infections. Auscultation reveals crackle, so again, pulmonary congestion, S3 gallop, right? So volume overload
mm,
and hollow systolic murmur at the apex. So we have
oh,
mitral regurgitation,
yes.
S3, and history of MI
Mm.
6 months ago,
Mm.
right?
Yeah.
And what else? What else?
Pulmonary congestion.
Yeah, and he has hypertensive, pulmonary
Yeah.
congestions,
Smoker.
and smoker. All right. So
Yeah.
smoker is significant for MI. All right. So
Yeah.
auscultation revealed crackers, apex. Now the patient is admitted to hospital, and after the treatment with diuretics and vasodilators, the conditions improve. So this is an important point. So the condition improves significantly, and no appreciable gallop and murmurs. So the mitral regurg and S3 gallop is now
Resolved. The volume is
resolved
replaced, right?
with diuretics.
Mm.
Yeah.
Let's see what the question is asking. Okay, which of the following best explain the murmur heard at the time of the initial examination? So why do we have the mitral regurg first and then it resolved? So can calcification be resolved?
No.
No.
So it's
No.
permanent, right?
No.
So we are not concerned about aortic valve, right?
Yeah.
No.
We,
No.
we, are, we are only concerned about the mitral. Okay, so chorda tendineae
No.
ruptured post MI can lead to mitral regurg,
But it will
right?
But
not
that
But
so
it's
cannot be
also
corrected.
permanent, right?
permanent.
It's
Yeah.
also been
Permanent.
permanent, right? Thickened and deformed mitral valve cusp. So it's in
Secondly.
rheumatic heart diseases,
Systematic
right?
fever. Yeah. Yes.
Yeah, so it's in rheumatic fever or rheumatic heart disease, and it's also permanent,
Per-
right?
Yeah.
So the secondary means due to other
Ischemia.
cause,
Yes.
right?
Yeah.
Yes.
So it's due to other cause, right?
Okay.
So what do you think could be the cause? So maybe the ischemia has caused the systolic dysfunction, right?
Mm.
And the systolic dysfunctions of the left ventricle is in leading to increased pressures, right?
Yeah.
Yeah.
Right. And
Yeah.
Complications of
age will
trauma
age.
months later.
Yeah, great.
Yeah.
So it is leading to increased volumes as we can
Yes.
hear the gallop, right?
Yes.
So systolic heart failure leading to
Yes.
increased volumes causing S3 and as well as mitral
Mitral.
Regurg.
regurg.
Yes.
And such type of mitral regurg which is not primary or intrinsic, we call it
Second.
secondary mitral
Intramitral Kirk.
regurg. All right.
Yeah.
Okay.
All right.
Okay.
Solving
Mm-hmm.
questions with you make it so easy, sir. To be honest.
Thank you so much. All right. I'm very tired today. All right. So, anyone?
Which of the following hemodynamic changes is most likely associated with this patient's current presentation? A 72-year-old man with long-standing dyspnea was seen in the clinic after experiencing an episode of syncope. Physical examination showed weak and slowly rising arterial pulses. Cardiac auscultation showed a harsh mid-diastolic murmur, best heard at the second right intercostal space with decreased intensity of the second heart sound.
So, what do
Electrocardiogram.
you think? Yeah. So, what do you think the sound is?
Mid.
Aortic stenosis.
No.
Aortic?
Stenosis.
Stenosis. Yeah.
Aortic
Right upper
stenosis.
sternal border.
Aortic yeah. Right up.
Yeah. Yes, sir.
And decrease is two, right?
Yeah. Second heart sound.
Yeah. So, the second heart sound is confirmed that we have aortic
Mind
stenosis,
stenosis.
right?
Yes.
Process.
ECG. Yeah, we are we are that much concerned they have given. Yeah, the ECG confirms the diagnosis of aortic
Yeah.
stenosis. Okay.
Yeah.
All right. You can go on with the question. All right.
2 months later, the patient comes to the emergency department with palpitations and increased shortness of breath. His blood pressure is 90 over 60 and his heart rate is 130 with an irregular rhythm. Electrocardiogram shows new onset atrial fibrillation without significant ST segment or T wave changes. Chest x ray
Mhm.
shows lateral pulmonary edema. Which of the following hemodynamic changes is most likely associated with this patient's current presentation?
Yeah, so let's go in a sequence, okay? So we have aortic stenosis, right?
Yes, sir.
Yes,
Right.
sir.
Yeah.
right? And that aortic stenosis is now causing the decreased blood pressure, right?
Yeah.
Yes.
Yeah, and what else? We have irregularly irregular rhythm and AFib,
Atrial
right?
fibrillation.
Without the without significant changes in the ST segment and T-wave, right?
Yeah.
Yes.
And chest X-ray also shows bilateral pulmonary
Edema.
Edema.
edema, right?
Yeah.
So
Yeah.
can it signifies the left atrial enlargement,
Yes,
Yes.
sir.
Yeah.
Yes.
right? So AFib and bilateral pulmonary edema. So yeah, which of the following hemodynamic changes is most likely associated with this patient current
Presentation.
presentation? So what do you think?
Increase ventricular filling.
Filling?
No.
Afterload.
No.
Listen,
Yeah, so if
Ventricular
the
system.
if the ventricular filling is increased, so we won't be having the decreased blood pressure as we have the normal ST segment and T wave, like the ventricles are normal, right?
Yeah.
Yeah.
Decrease in ventricular preload.
Increase after load.
There is increase after load in left ventricle
Increase
because
after load because of
Increase in left ventricle afterload.
aortic
No,
stenosis.
decrease.
yes.
Yeah.
Sudden increase in left
Can we say that
ventricular.
the function of the
Decrease
left
in
ventricle is
preload.
decreased?
Sir, please solve the question, sir. We are going.
Only.
So isn't it like we have aortic stenosis, so blood
Yeah,
will
so
pool up
let me give you a clue. The problem is they are more focused about the atria. The atria is the left atria is now not
Not
properly
Closing.
contracting.
contracting, okay?
In
And
serious
we can see
yeah.
because of the aortic
Atrial
stenosis, and we
Stenosis.
have now atrial
AFib.
fibrillation, and I have told
Fibrillation.
you we have left
Yeah.
atrial enlargement. So
Yeah.
now all the thing could be explained like we have no atrial kick.
Yeah.
yes.
So
B.
Yeah.
right,
Yeah.
Yeah.
Mm.
Yes.
Yes.
the problem we are facing is due to aortic stenosis, the pressures are rising, right, in the left ventricle, and it will is the left atria, leading to enlargement of
left
left atria. And maybe the pressures are that much increased that further coming down of the blood is ceased. All right. And the atria gone into AFib, right?
So why not
Mhm.
D? In case of aortic stenosis, there is increased
Mm-hmm.
pressures. There would be increase after load, I think. So why
Yeah.
not D?
So what about the sign and symptoms after that? If we have like increase left ventricular afterload, right?
Yes,
So
sir.
what do you think we would have like? What would be the effect on the sign and symptoms?
Hypertrophy. Hypertrophy would be there, maybe if it is for long time.
Hypotension, right? We will have hypotension, which is given, right?
Yes, sir. It's a bit confusing for me.
Yes.
Hypertension or
Yeah,
hypo?
hypotension, right? No,
We
Hypertension.
have
hypo.
hypotension, not hyper. You will have afterload increase in hypertension. The what we have is hypo. So here we have the left atrial contraction is lost because we have
Yeah,
AFib, we have
the
stenosis.
So
So
up
I
the
am
that is
afterload.
going to increase cardiac output or decrease
Yeah.
cardiac output. And when cardiac output is decreased, after that's the one you have a decreased left ventricular systolic function because of lack of contraction.
I'm
Yeah,
sorry to
and
interrupt. I was just
yeah,
talking in
uh-huh.
relation to aortic
Hmm.
stenosis.
Yeah.
Two things, both aortic
Mm-hmm.
stenosis and atrial fibrillation, not just aortic stenosis. You
Mm-hmm.
understand? I understand. Yeah. So that's why, because of the left atrium that
Mm-hmm.
is not contracting. So that will
Yeah,
make
but I
preload
guess
to be
yeah,
free.
but I guess in case of increased left ventricular afterload, we will have like what do we call the gap? Like
SVR.
the systolic
Resistance.
and diastolic blood pressure gap will be there, right?
Yes. Systolic
What do
will
we
be
call the
high.
gap? Sorry.
Pulse pressure.
Systemic
Pulse
vascular
pressure.
resistance.
Pulse
No,
pressure.
pulse pressure. I'm
Yes,
tired.
pulse pressure.
Sorry.
Pulse pressure.
Yeah,
Okay.
so we will have uh, uh, increased pulse pressure, right? The systolic blood pressure is increased because of the increased afterload, right? And the diastolic will be decreased because of the decreased cardiac output, right? Right,
Yes.
guys? Or
Actually,
did
doctor,
you?
your initial explanation was the easiest one, that they're focused more on the left atria at this time and they're
Yeah,
asking what's the cause of the current presentation. So,
yeah, and yeah,
AFib
that
and
that's
the, yeah.
also. And the second thing
Yeah.
is the left atrial afterload is increased, so we will have like 170 or 70 such thing like that, or 160 or 70. Okay, so we will have increased pulse pressure. Okay,
Pulse pressure. Yeah.
because the afterload we have increased systolic blood pressure and the diastolic is decreased because of decreased cardiac output. Okay, all right.
So now, doctor, what I get, they just give us the aortic stenosis just to give us the cause of AF. But the main
Yeah.
important that there's an AF. So
Mm-hmm.
why, what's going to happen, whatever. That's it,
Yeah,
right?
Yeah.
so it's pretty
Yeah.
clear. In
Yeah,
in
it's clear
AF
like
we
that.
have
Yeah.
yeah, in AF we have
Atrium system.
no atrial kick, right? Or we can
Yeah.
say no atrial contraction, which is leading to decreased preload, okay?
Yeah. This is
So
clear. Yeah.
don't make yourself confused, okay?
Yeah.
It's most of like a physiology
Yeah.
question. That's why we have
I also want
this
to
specific.
add, this is
Mm-hmm.
a problem of hypertrophy, right? Concentric, right? So concentric is a feeling problem. And when there is feeling
Yeah,
problem, the contraction is not happening because the blood, everything is just stasis, it's not moving. So that's why the pressure, the left ventricle preload is not coming more. It's gonna decrease. So because
yeah.
there's no, yeah, blood is not threatening.
So all three explanations, all of you have done great job. And yeah, that's how physiology is, okay? Yeah. Sorry.
Right.
I again pressed the option D, okay?
It's okay.
All right.
Yeah.
So I guess it's the last question to be discussed, okay?
Okay.
And yeah.
Okay.
Yes.
All right. So anyone?
Which of the following changes is most responsible for maintaining cardiac output in the setting of this valvular abnormality? 44-year-old man with a history of IV drug use came to the emergency department due to fever and chills. Multiple blood culture sets were positive for Staph aureus, and patient was diagnosed with infective endocarditis. He was successfully treated with a long course of antibiotics. 6 months later, he returns to the clinic for follow-up evaluation. The
Mm-hmm.
patient has no symptoms and reports a good exercise tolerance. He is afebrile, blood pressure is 140 over 62, and pulse is 82 per minute, and respirations are 16. Chest auscultation reveals decrescendo diastolic murmur over the third intercostal space along the left sternal border. Echo shows severe aortic regurgitation, likely as a sequelae of the prior infection. Which of the following changes is most responsible for maintaining cardiac output in the setting of this valvular abnormality?
So we have 6 months previous history of infective endocarditis due to Staph aureus, and the patient was IV drug abuser, right?
Yes.
Now he is afebrile, but he has a left sternal border diastolic murmur, right? Decrescendo diastolic murmur, and they have given you as an aortic regurg, right?
Yes.
left sternal border and third intercostal space, right?
Yes.
Echo shows aortic regurgitation. Yeah. So we have aortic regurgitation is a sequela of prior infection. Which of the following changes is most likely responsible for maintaining the cardiac output and the setting of valvular abnormality? So
Stroke
what do you
volume.
think aortic regurgitation leads to?
Eccentric heart volume.
Increase
Volume,
volume,
yeah.
Volume.
right?
Volume.
Increase volume.
A lot. Yeah.
Eccentric,
Volume.
eccentric hypertrophy, and I have told you
Hypertrophy.
we have normal ejection fraction, right?
Fraction.
Fraction.
So
Yes.
that's all you know from the previous
Yeah.
knowledge, okay? Now we have dilated left ventricle, right?
Yes.
So
Yes.
at first
Yes.
we have 100 volume. Now it's accumulating 130, okay?
Yeah.
Right?
Yeah.
Yes.
Yes.
And the ejection fraction is normal.
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 So let's assume first it's ejecting 50%, right? So it's
Yeah.
50, right? Now it's ejecting again 50%, which
Yeah,
is
that's normal.
75,
70.
right?
Okay.
Yeah.
So what's increased?
What? Um,
Vol
what?
uh,
Preloads.
Systolic
Stroke volume, yeah.
stroke volume.
stroke volume.
Stroke volume, right? So
Yeah.
simple again. What's happening? We have aortic regurgitation, which is leading to eccentric hypertrophy, right?
Yeah.
And eccentric hypertrophy is the we can
Normal
say the
ejection fraction.
response to maintain the cardiac output. Okay, so like we have discussed in the swimmers, right?
Mm. Yeah.
They wanted to increase stroke volume, and what the heart did, that it hypertrophied is in eccentric hypertrophy, right? And what
Yes.
happens in eccentric hypertrophy, that the ejection fraction is remains normal, right? So let's assume that if first we have 100 ml of volume in the left ventricle, right? And 50% is ejected, right?
Yes.
Now, after the eccentric hypertrophy, the volumes becomes 130, right?
Mm.
Yes.
Yes.
Is it's dilates, right? In eccentric hypertrophy, right? And why
Mm.
it's doing that? To meet the requirements, right?
Mm.
Yes.
All right. Yeah.
Yes.
So what is happening again? The ejection fraction is normal. 50 was here and 50 is here. So what's the 50% of the 100? So it's 50, right?
Mm.
Yes.
And if you see the volume is increased, but still it's ejecting 50% of the same volume. So it's
Yeah.
become 75, right?
Yes.
So
Yes.
what we assume that in eccentric hypertrophy, the stroke volume increased to meet the
Compensate.
requirements
Requirement demands.
Mm.
or demands, okay?
Yes.
Right? Yeah, so what is maintaining the cardiac output? Now look over to the answer.
Stroke vo-
What I think Frankenstein. Frank was low.
E. E.
E.
E
E increase
increase in
the
left ventricle
stroke
stroke
volume.
volume.
Stroke volume.
Right?
Mhm.
Yes, sir.
Increase in the left ventricular stroke volume, okay?
Yes, sir.
All right. So I think that's all for today. And if you want, we can take tomorrow classes in pathology. And if you want, we can take tomorrow classes in pharma. What do you think?
Do we have other
Pathology.
subjects in pathology, doctor?
Pharmacology.
Sorry?
Pathology, doctor.
Pathologist.
What other
Pathology.
subjects? There
Pharmacology.
are different subjects, I mean pathology, or the same?
I think we have one more section to cover, right? Like
Yeah, so we
the
have like 25 questions
Vasculitis.
remaining.
vascular,
Yeah, we
yeah.
have 25 questions remaining from the
Yeah. So
pathology,
we
and I guess we haven't done the vasculitises.
yeah, we
Yeah,
can
better
one.
pathology
Good.
if
Today we
All
covered
right.
day 7 or day 9.
Today, I think it's the 7, right? Yesterday
And we
Yeah.
have
was
more,
Day
two
eight.
day
more.
8.
8.
Mm.
So
Um,
tomorrow will be day 9 and then
Okay.
pharma, right?
Farmer. Okay.
Yeah.
All right.
Great.
okay, doctor. Thank you so much.
Thank you guys.
Thanks a lot.
I hope you
Thank
guys
you.
have I hope you guys have understand the sounds, murmurs.
Yes, sir. Thank you so much for
Was great.
explaining. We have
Thank you, Dr.
confidence in that for. Thank you.
All right. Thanks a lot.
Thanks a lot.
See
Was a
you
great
tomorrow.
topic.
Take care.
Inshallah.
Tomorrow.
Bye bye.
Thank you, guys. Thank thank you. Take care. Bye bye.
Bye. Thank you.